I think that's a
Yes,
good start
okay now.
right now.
Yes.
Excellent.
Thank you, Jamal.
Zainab, over to you.
Okay, so good morning, everyone, or good afternoon, depending on where you are, where you are located, and welcome to today's webinar on human rights and gender-based approaches in malaria programming community system, strengthening to the malaria constituencies in Anglophone Africa. So my name is Zainabou Ide. I'm the program officer from the MGO Impact Santé Afrique and the global platform CS4Me. I have the honor to co-moderate this training session with Olive Mumba, Mrs. Olive Mumba, the Executive Director of ENIASO. So I will give you the rules of usage before the webinar begins. First of all, please write your name, organization, and email in the chat box so that we will send you the full presentation after the webinar. And we also have a Q&A session at the end of the webinar, but feel free to ask questions or to make some comments in the chat box during our panelist presentation. Thank you. So actually, we will start the presentation of CS4Me. Sorry, maybe Olive, if you have the CS4Me platform.
Okay, you please proceed to present CS4Me, and then I'll come back to the agenda. Thank you.
Okay. So CS4Me is the global civil society and community civil society for malaria elimination, and we launched the global platform in 2019. And the CS4Me vision is a world free from malaria, and our mission is to make malaria programs and interventions more effective, equitable, innovative, inclusive of civil society, community-based, human rights-based, gender-sensitive, and adequately funded. So actually, as for the membership, we have 218 members in 47 countries of Africa and South Asia. So to join us, a link is available after the presentation. You can click on it, and then you can have the process to be a member of CS4Me. So CS4Me areas intervention are to connect CSOs into a single global platform, encourage source-to-source collaboration, to increase knowledge and information sharing on malaria, sharing on malaria strategies and new findings, to strengthen capacities of CSOs and provide trainings, to promote involvement of CSOs in decision-making spaces at all levels, to reinforce the sense of urgency to eliminate and collect local voices, to advocate for sufficient malaria funding and allocation for CSOs and community-led interventions, to promote universal access to existing tools and demand new innovative tools, and for the end, to keep our leader on ourselves accountable. Next slide, please. So we have a brief presentation of what is CS4Me, on what is CS4Me in English.
Zainab, we can't hear. I don't know whether it's only me.
Okay, can you hear now? We are coming. Maybe there is a few.
50% de la population mondiale est actuellement à risque. Mais ce sont les personnes les plus vulnérables qui en souffrent le plus. Ce sont les femmes enceintes, les enfants de moins de 5 ans, les réfugiés.
It looks like the presentation is in French.
We are actually, the English one is playing, but I think that there is a problem of the sound.
Okay.
Yes, but okay, maybe at the end of the presentation we will.
250,000 children could not see their fifth birthday because of a mosquito bite.
These people needlessly carry the burden of a preventable and curable disease.
In Africa, malaria is among the leading causes of death.
Olive?
It was working there in English.
Yeah, it had started coming in English. And sorry, I think technology and our internet sometimes is very erratic. Thank you so much, Zainab, for trying. What you can do is kindly share the link so that we can all have the presentation. And thanks for introducing us to CS4Me. And for those people that are on the call, kindly link up with Zainab, with Olivia, so that you can also become a member of CS4Me. So coming to the agenda today, we will be we have a great panelist. We will start off with Ms. Gemma Obeth, Dr. Gemma Obeth actually, and she is the regional coordinator for the CRG platforms within the Global Fund. She will just give us an overview of the current Global Fund strategic plan, but also inform us on what's happening as the Global Fund develops its new strategy. And this is with the aim for us to be able to know and to engage with the processes that are currently happening. And then moving forward, we will be talking about community system strengthening, human rights, and gender-based approaches in malaria programming in Anglophone Africa. And Onesmus Mlewa, who is the technical support manager, will give us, will unpack the community system strengthening in Global Fund programming, but we'll also bring in Cecilia Seno, who is the executive director of HFFG, it's an organization based in Ghana, and she's going to just give us experience from Ghana, HIV/TB programming. And then we will move on to Sophie. Sophie works, she's the global coordinator for Women for the Global Fund, and she's going to give us some highlights and unpack gender-related issues, but also gender in malaria programming. And she will be backed up by Carol Nawina, who is the executive director of Sitam Plus, based in Zambia, who also give us the experience in the TB in the mining sector in Southern Africa. But her organization is a sub-sub recipient, so she will also be sharing their experience. We will be joined by Alexandrina Lovita, who is the technical advisor and human rights within the Community Rights and Gender Strategic Initiative in the Global Fund, which is the same strategic initiative Gemma works in. And she will be providing us highlights on human rights related issues in malaria programming. And then we will then have Nana Gleason, who works with Bonella, and she will be giving us experience of Botswana, from Botswana. I remember, Nana, you're also supposed to share in terms of human rights and specifically around how HIV programming has happened. And then we will have a session, which is going to be a Q&A, where we'll be having time for us to discuss, and then Zainab will come back again to give us the closing remarks. What we've done is, after Gemma's presentation, we'll give just a few minutes for people to, for us to just have a short discussion. But once we start this community, the CSS, the gender and human rights, we will request you to use the chat box. So please look at the chat box and put all your questions either in the chat box or in the Q&A session. And during the Q&A session, we will come back and discuss this. So with that, can I kindly request Gemma, if you can put up your presentation, or is it us who's putting up the presentation?
I would like to share, but I need to be permitted first.
Okay, so Zainab, if we can permit
Or
Gemma to be able to present.
maybe
Okay.
if I do it, it will override what's there now, but maybe that's okay. Is that fine? Okay, there we go.
Okay, it's okay now. You can go.
All right, everything is fine. You can see?
Yes, we
Yes,
see.
we can see.
Thank you.
Thanks. So I'm going to give a short presentation, just a few slides, to introduce the Global Fund's current strategy, which runs from 2017 till 2022, and a brief introduction to a process that is just started to develop the new strategy. I know 2023 seems a long way away, but it's a big process, a very important one with lots of consultation, so it's already starting. So what is the Global Fund and what does it do? Just as a basic introduction, it's a partnership designed to accelerate the response to the 3 diseases and mobilizes more than $4 billion per year, which is a lot of money, in more than 120 countries. So one of the most significant funding sources for the 3 diseases, and malaria included. We work in partnership with governments and civil society and communities and other technical agencies, like RBM, for example, and World Health Organization, to do our work. We're guided by a strategy, as I mentioned, which I'm going to go into some details about now. And that strategy has 4 strategic objectives. The first one is to maximize impact against HIV, TB, and malaria. The second one is to build resilient and sustainable systems for health. The Global Fund's third objective is to promote and protect human rights and gender equality. And the fourth one, very important for a donor, is to mobilize increased resources. So the strategy is aligned to the global targets set by our global technical partners, namely UNAIDS, WHO, and Stop TB as well. So what this means is the Global Fund doesn't set its own targets. We invest in programs that will achieve globally agreed targets. So when we look at malaria here, we want to, let's look at 2030. We want to reduce mortality by at least 90%. We want to reduce malaria incidence by at least 90%. And we want to see 35 countries eliminate malaria altogether. So my next slide, I'm going to focus in on this diamond here, which is the green one. And that is on promoting and protecting human rights and gender equality. Now, I think that the entire Global Fund strategy is relevant to us. So not to say that it's only this corner, but for the purpose of this webinar and its themes, I'm going to focus mostly on the green diamond. So you can see the green diamond there has 5 what they call operational objectives, or like a sub-objective. Oops, don't know why that happened. Maybe it's on a timer. Sorry. So the first one is to scale up programs to support women. Sorry guys, there must be an animation in my slide. 1 second. It's making me jump to the next one.
You had timed yourself for 5 minutes.
Maybe. How do I make it not jump? I can't see. Where is that? Who's my PowerPoint expert? I can't see any animations. That's weird. Okay, I'm just going to go out of full screen so that when I show
Gemma,
this,
do you need any help?
if you have a solution for me, that would be great. But I'm going to present it.
Start from our screen. If it can help you.
It's something embedded in the presentation, I think. I don't know. It's obviously on a timer, but I didn't know that.
Okay, so let's try with our presentation and we'll see if it works.
I think it's the same presentation, right? So I think it will.
Yeah.
It's okay. Don't worry. I think we can just see like this, right? And then I'll go back to full screen afterwards.
Okay, so let's try and then we'll see.
No. Oh, okay. Can I share my presentation again?
Zena,
yes, Olive.
Gemma, what Gemma is saying is because it looks like the presentation has been timed. So even if you share, what will happen is it will remove as well. So let Gemma just put it on, give her the co-hosting so that she can just, she will not use the PowerPoint, but, sorry, she will not use the screen, what is it called? The bigger one, but the English is a problem. There's a way of controlling.
So Gemma, go ahead, please. You can share your screen.
Exactly,
Thank you.
It's something embedded in the slides that I didn't know was there and I don't know how to get rid of it. Okay, so I just want to go over those 5 sub-objectives. I hope you can see. Maybe I can zoom in a bit more. There we go. So the first is to scale up programs to support women and girls, including programs to advance sexual and reproductive health and rights. The second one is to invest to reduce health inequities, including age and gender-related disparities. So that's kind of a strange wording, but basically what it means is that if there are certain diseases which are affecting young people or young women in particular, if there are disparities in disease burden, which we see in malaria, particularly for gender, in terms of pregnant women, but also in terms of age, in terms of children. So we want to invest to make sure that there are no inequities in terms of burden and in terms of access to services. The third one is to remove or introduce and scale up programs that remove human rights related barriers to services. So we've got a lot of understanding about this in the HIV field and increasingly in the TB field, but I think we still need to develop better understanding in malaria about human rights related barriers to access. These could include things like stigma, it can include things like attitudes of health workers or access to financial resources to travel for services, things like that, age of consent laws to access services. And we have a malaria matchbox tool that helps us to identify these issues. We want to integrate human rights considerations throughout the grant cycle. And lastly, this is a very important one for the partners hosting this training, and I think this training is contributing to this objective, is to support the meaningful engagement of key and vulnerable populations and networks in global fund related processes. So this means understanding the processes, understanding how we can engage, understanding where is their support available, how can we ask for assistance, and things like that. Okay, sorry for the issue with my slides. Now I can proceed. So to date, the Global Fund has achieved really remarkable results, and particularly in malaria here. We've got 100, and these results are fresh off the press, as they say. They came out yesterday. These are the Global Fund's latest results for 2019. So we have 160 million mosquito nets distributed. So that's a massive increase from, I think the last year it was 114, if I'm not mistaken, something like that. So a big increase. And you can see in these 3 pictures, mosquito nets population coverage down from down here in 2010 up to here, up to 58% in 2018. So it looks like we're on track, right? To get to our target. Don't you think? That one looks like it's going in the right direction and is on track. And mosquito nets per population in use, we go from 30% to 51. Again, it looks like we're on track there, right? Then again, if we looked at suspected malaria cases tested, from 67% to 90, probably actually we're ahead of schedule on this one. So some really good results here for malaria. However, we have challenges as well. So while the coverage of nets is increasing, the use of nets is increasing, we are off track to reduce incidence. You can see this is our trend for malaria cases. This is if we continue with business as usual, but this is where we need to go. So we need to accelerate our progress. We're doing a little bit better for the mortality. If you look at the black line, the continuation of our trend is still off track, but I think we can course correct and get on track to achieve the WHO targets. So that's what this slide confirms, that we're likely off track, but mortality is declining, and it's not impossible to really course correct and intensify our approaches. And if we look at where the burden is, we can see the high burden countries are really concentrated in Africa, in West Africa, Central Africa, and couple in East Africa, and then Mozambique, and also in South Asia as well. So we need a highly focused geographic response as well. And some of our countries in Africa are approaching elimination, which is exciting. So what about our progress and challenges in terms of human rights and gender? I think this image is very key for us. I think it highlights the equity issue for malaria very well. So if we look at the percentage of children who are tested and test positive for malaria by their wealth quintile, this is looking at low-income countries at the top and lower middle, you can see it's really the poorest children who are burdened with malaria. The red ones are the poorest children, the green ones are the richest children, and the yellow is in the middle. It's such a clear inequity, isn't it? When we look at who is affected by malaria. And there's a whole bunch of reasons for that. But this is a key one. Inequities persist across income, geography, age, and sex. And these are key issues the Global Fund is interested in addressing. You remember that sub-objective, we want to address age and gender inequities in the 3 diseases. And I think for malaria, that's a really key one. When we look at gender as well, we can see there's an urgent need to address these gender-related barriers. We know for malaria that pregnant women face severe risks. And we also know that in West and Central Africa, more than 1/3 of pregnancies are exposed to malaria. So that's a key sort of gender-related issue that we need to make sure is addressed there. And of course, human rights is also a very important opportunity for the strategy. Alexandrina will talk about the Breaking Down Barriers initiative later, but this started as a focus on human rights in the context of HIV, but now the investments are across the 3 diseases. So countries are receiving additional funding for human rights, and this includes to respond to human rights in malaria context. So looking forward, it's 2020 already, and we're starting the process to develop our new Global Fund strategy, because it's already halfway now with our current strategy. So the next strategy, we need to set out how the Global Fund aims to, really consolidate progress towards achieving 2030 goals. So at the moment, the Global Fund is asking stakeholders to provide input. So raise your voice. What should the Global Fund strategy include? Are there objectives missing? Do we want the same ones to continue? So there are opportunities to have your voice heard. And my last slide just has some information on that. So you can please visit the Global Fund's website. It's globalfund.org, and then you go /strategy development, and there's lots of great information. There's a survey where you can engage, or you can just send an email if you like, sharing your opinions, sharing your views and experiences. That's also possible. So that's all I have for today. I'm happy to answer any questions, although I see that we're a little bit behind time, so I'll turn back over to our moderator now to facilitate. Thank you.
Okay, well, thank you very much, Gemma, for your presentation. Thank you. It was very clear. Actually, we don't have a question yet, but please, to repeat, if you have any question or comment about Gemma presentation, you can put it in the chat box and the Q&A box, so that we will send her your question, and then she will reply to you. Thank you very much, Gemma, once again. So we have the next presentation with Onesmus Malewa. Hello, Onesmus Malewa.
Very much, Zainab. Would I be given permission also to project, or what happens?
Great. You can project from your screen.
Okay, thank you very much, Zainab. Let me share my screen.
So just before Mlewa comes in, we are going to have a series of presentations. So if you have any questions, kindly jot them down in the Q&A or in the chat box. After all the presenters have finished, we will have time to do the presentation. So right now, let's move over to Mlewa.
Thank you very much. Hope you can all see my screen.
Yes,
you can see my screen. Thank you very much. So I will try to also take a very short period of time presenting community system strengthening for global fund programs. And before I actually talk about what community system strengthening is, I just have a slide here that reflects on what communities actually do to influence health outcomes. In a nutshell, communities do quite a lot of things. Communities monitor performance of programs. They observe, they see, they have opinions. Communities normally use evidence to influence decisions. Communities do social mobilization. Communities do linkages so that they can be able to ensure that different partners put in place the right initiatives to impact on their livelihoods or their health standards. Communities do networking and collaboration. Communities do institutional capacity building. We also do planning and leadership development, as well as monitor efficiency and accountability. These are the many things that communities do on a day-to-day basis. However, a critical challenge comes in that some communities actually do not have the right capacities to perform these very regular roles that communities normally do to influence health outcomes in their own countries. So, given that background of the so many things that communities normally do to influence health outcomes, what then is community system strengthening? And actually pulling this definition from the Global Fund, it's actually an approach that promotes the development of informed, capable, and coordinated communities and community-based organization groups and structures so that they can actually be able to respond effectively to the health challenges. So in a nutshell, what community system strengthening then means is basically investing in the system's pillars. What are the pillars that actually form community system strengthening? And the pillars actually encompass all the functions that I've just described earlier. We have actually about 6 pillars which we focus on too when we talk about community system strengthening. And we are talking about community-based monitoring, evaluation, and learning for accountability. That's one thing that needs to be strengthened in communities. We are talking about enabling environment and advocacy for social accountability. We are talking about community networks, building community linkages, collaboration, and coordination. We are talking about institutional capacity building and leadership strengthening, implementation of capacity effective service delivery, as well as resource generation and capacity strengthening. So basically, these are the 6 core pillars that relates to community and communities. And when we talk about community strengthening, is basically ensuring that these pillars actually function optimally. So when we talk about community-based monitoring for accountability, basically what are we talking about? We're actually saying community-based organizations and other community groups should be strengthened enough to be able to monitor, document, and analyze the performance of health services as a basis for accountability, advocacy, and policy activities, so that they can actually be able to use this evidence to say this is exactly what we need to do. So that's exactly what we mean when we talk about community-based monitoring. And it calls for supporting training of communities, monitoring on monitoring and evaluation, and how to translate outcomes into results. This is basically what we're talking about, strengthening the community-based monitoring pillar for community health system strengthening. When you look at advocacy for social accountability, what are we really talking about here? What it means is that communities and affected populations conduct normally consensus building dialogues and draw actions or priorities that they can use for advocacy at both local and national levels. The use of community-generated analyzed evidence to hold decision makers accountable. This is basically what we are talking about on advocacy for social accountability. Advocating for availability, accessibility, and acceptability of health services, as well as broader issues such as discrimination, gender inequality, and sustainable financing aimed at social transformation. Just what actually Gemma was talking about. When we talk about community networks, building community linkages and collaboration and coordination, what are we exactly talking about? As in this pillar, we are talking about communities and affected populations being able to engage in activities to improve health outcomes within their own environment. And this is normally achieved through community action and social mobilization. This is where communities are actually able to have the ability to mobilize and come up with effective community actions actually to turn down the tide. Establishing of community organization and reaction of and creation of networks. This is where actually communities pull together for a common purpose, effective linkages with other actors and broader movements such as human rights and women's movements. So the ability of communities to be able to perform these functions actually strengthens the community networks. Building community linkages and collaboration is another pillar that needs to be strengthened for when we are actually talking about community system strengthening. And when we talk about institutional capacity building and leadership gathering, this is all about capacity building of community sector groups necessary for them to fulfill their roles in service provision, social mobilization, monitoring, and advocacy. Institutions need to be capacity built. And this is a challenge that many community groups, civil society organizations have always experienced, that they do not have the right capacities to actually do planning and organizing and the entire range of systems development, human resources, leadership, and community sector organizing. When we talk about resource and capacity building, this actually relates to human resource skills. Do we have the right human resource skills within our community groups or a civil society organization? Sufficient and sustainable financial resources to be able to actualize our actions, as well as adequate material resources that includes infrastructure, information, and essential commodities. And then finally, the last pillar, we are talking about community activities and service delivery. Communities are well known in actually reaching areas that formal systems are actually unable to get into. So actually strengthening the capacity of communities to be able to deliver these essential services in areas that formal systems are not able to is a key strong pillar for community system strengthening. So we are talking about delivery of quality community-based activities and services, as well as effective and high quality services and interventions equitably delivered to target communities. So basically, the rationale for investing in community system strengthening is actually maximizing impact. That we know communities bring to the public health discourse a lived reality. They're the people who actually really experience the issues out there. And they have a wealth of skills, knowledge, and understanding of the real consequences of the disease burden. With the essential support provided to strengthen the capacity of communities, these are actually the likely impact we are actually talking about. Improved outcomes for health and well-being, respect for people's health and other rights, social and financial risk protection, improved responsiveness and effective interventions of communities, improved responsiveness and effective interventions of health, social support, education, and other services. This is actually the benefit of actually investing in community system strengthening. As I finalize my presentation, this is basically how it works. if we invest in community system strengthening, we actually are going to have actually improved health outcomes. And giving this example that we have actually provided this illustration that speak from the Global Fund, you can see by actually strengthening the 6 core pillars of community health system strengthening, we are likely to lead to quality services available and used by communities. And in the long term, we are talking about health is improved at the community level. And below, we have actually such examples, like for instance, if we have a mass distribution of insecticide treated bed nets, community actors will visit homes to provide information on the correct use of these bed nets. So communities must be incapacitated. They must have the right capacities to be able actually to have the right knowledge, move out to communities and actually provide this information. And then we're actually going to have community members ensuring that the bed nets are used by those most vulnerable to malaria. And in the long term, we are talking about reduced number of malaria cases in the community, as actually we have seen that we are actually really increasing community bed nets. So basically, this is how the framework of community system strengthening works. And at that particular point, I know we really don't have much time. So thank you for listening to me. And I'll be ready to answer and respond to many of the questions. I know I have rushed, but I know it's because of the time we're having. Thank you very much.
Thank you so much, Mlewa. Thank you for presenting us and providing us with what community system strengthening is really about, and in terms of the policies from the Global Fund and examples of how community system strengthening has been incorporated within our Global Fund programs. Now, I want us to quickly go to Cecilia. Cecilia, we want you to give us 3 pointers on how you feel, how HIV/TB has been integrated within CSS, Community System Strengthening, in Ghana. So can I hand that over to you? And colleagues, as I'm handing this over to Cecilia, kindly remember to jot in your questions. I see we have 2 questions, and your comments in the Q&A box, but any comments you also have within the chat box. Thank you. Over to you, Cecilia.
Okay, thank you, Olive, and thank you, Mlewa, for this detailed presentation. In Mlewa's presentation, all that he said is not very different from Ghana, but our community system strengthening, I will talk first about HIV. HIV is well integrated into the CSS program. What we do as a country is to work directly with National Association of Persons Living with HIV, National AIDS Control Program, and then all other institutions, Ghana AIDS Commission, to ensure that services and the voices of persons living with HIV, young people, AGYW, and everybody is well heard. Now, in Ghana, what we do is to ensure, NSCP is the one who is responsible, NSCP and is under Ministry of Health, who is responsible for treatment. But what strategy we use in Ghana is a Models of Hope strategy. For Models of Hope are men and women and young people living with HIV who are trained to provide HIV interventions to their peers at the facility. So every facility where ART is, we have at least a minimum of 3-4 persons living with HIV to provide psychosocial support, and then encourage newly diagnosed and also ensure that people adhere to treatment. And this is actually under CSS, working directly with Ministry of Health, Ghana Health Service in all ART facilities. And so they also ensure that defaulters are brought back to treatment. They follow defaulters to the communities and ensure that all those defaulted, and this is fit into the Ghana Health Service system, they provide the list of defaulters, and then they trace people to the grassroots and bring them back to treatment, which is very important. And also we ensure as a country that TB HIV is integrated into CSS. And so with the CSS intervention, we work a lot with Stop TB Partnership and TB Voice Network, where we use this strategy of cure TB clients, also providing screening and bringing infected people from the community. So they do the presumed cases, they screen them, and then work closely with Ghana Health Service and link them to treatment and ensure that they adhere to treatment. They also, again, trace defaulters to the community and bring them for treatment. And in fact, one important thing we did was we are doing now under CSS is to strengthen networks of communities. The communities of HIV, which is NAPLA's National Association of Persons Living with HIV, strengthening their capacity to be able to lead the implementation of HIV interventions. And one important thing that we are doing under this is also community CBMF, where communities, key population, persons living with HIV, malaria NGOs, TB NGOs, young people living with HIV are all trained, capacity built in community monitoring to collect data on services at the facility and identify gaps for advocacy. And so this group of people, we call them cadre of community members. They engage government at all levels. And so at the community level, at the district level, at the national level, they work with national advocacy groups and civil society organizations to ensure that services reach out to them. And they monitor services and then availability of drugs at the various levels. And then they feed back to the national group, and they go directly and engage government, the minister, everybody on the status of services. They also advocate and ensure that quality of service to them is very important. I think one thing that we do under the CSS is to ensure that gender, women issues are integrated into whatever we are doing. And so as we recruit different groups of people, we also take into consideration gender. And so what we do in addition is to also get other advocacy organizations, civil society networks, and provide some kind of administrative support to them to be part of the TB, HIV, and malaria intervention. And so there is monthly support under the CSS to ensure that they have very strong administration. And again, under the CSS, there are a number of capacity building interventions that we put for these networks and their members to be able to support program intervention at different levels. So with the CSS for HIV, there is a greater voice of persons living with HIV. And also, apart from all this, there is a lot of issues on human rights into HIV, because we are implementing the human rights intervention. And so human rights for persons living with HIV, key population, and working closely with police service and law enforcement agencies. And then we have paralegals who are lay people trained to engage where there are issues, and then they quickly bring up abuses and any gender-based violence up to the legal team and WAPCAS, which is also working, that we are, as the PR, that we are working under as a CSS SR. And so what I will just want to add to this, in addition to what Lenward talked about, is civil society, or will I say communities, are giving a lot of voice at different levels, forming linkages. And so in the communities, we have persons living with HIV, we have TB infected clients and cure TB people forming a group. And this group are networks that work together and support each other to form a very strong advocacy group at that level. And so issues and gaps identified during community monitoring, they come together to engage whoever the service providers at different level with the SAMC social accountability monitoring groups, which are also part of it. And they make sure that they engage and ensure that the right treatment is given to them. And they also create linkages for treatment and then linkages for affected people at different levels. And I would say that with the community system strengthening now, we have very stronger networks, especially making sure that TB voice, cure TB people now have a stronger network. And then we ensure that at regional, every region, we have their executive committee that really make sure that TB is voiced. And then malaria network, NGOs of working in malaria also come as a very strong organization, even though there are some challenges that we have, but also working closely, and the CSS district manages them and the workers, and they get their program resources to make sure that they engage at community level, they monitor distribution of net, they report, and also work with community volunteers to participate actively in the CSS implementation. So briefly, this is what I will talk about, and I'll wait for questions. Thank you.
Thank you so much, Cecilia, and thank you for taking us through the actual practical areas that you in Ghana have been able to do. You talked about the voices of the affected communities through strengthened network organizations, strengthening their organization, institutional, what is it, OD, as an organization, but you also talked about advocacy with key stakeholders, key decision makers, but you also talked about community-led monitoring and social accountability, meaning that all that has been integrated. Why we are sharing the HIV-TB experience is because, as you have mentioned, malaria is lagging behind, and we are hoping that by sharing these experiences, we are also going to challenge our colleagues from the malaria constituency to also make sure that when priorities are being set, we are on the table and we are ensuring that community system strengthening is integrated within malaria programming. We will not at this time, we will move forward, and the next presenter.
So we better buckle up to understand how we can work together in such a way that we don't abandon TB. And as a matter of fact,
excuse me, sorry, it looks like there was someone who came in. So the next presenter is Ms. Sophie Demutis. As I mentioned, she is the Global Coordinator for Women for the Global Fund. And she is going to talk to us around unpacking the gender-related issues or gender within malaria programming. So after Sophie, we will then have Carol to come and present. Sophie, over to you, please. Thank you.
Thank you so much. Can I just check in that you can see the slides?
Yes, yes, you can see the slides. Thanks, Sophie.
Thank you so much. Thank you for inviting me to speak this afternoon. The previous session as part of this webinar series was on June 16th. So today I'm presenting similar slides, but giving you a little bit more and going a little bit deeper. I'll also try and recap so that if there's anyone who's listening to this for the first time, you should be able to follow. So whilst we know that all people are exposed to malaria and can be affected, the risks of exposure and limitations to accessing adequate prevention and treatment remain disproportionately high amongst women, and unequal gender roles and gender dynamics give rise to different vulnerabilities. So this is, as Gemma mentioned, also a combination of biological, socioeconomic, and cultural factors that increase susceptibility amongst women, specifically adolescent girls who are between the ages of 15 to 19, women living with HIV, pregnant women, and women from key populations, including transgender individuals. So about 70% of malaria deaths are amongst pregnant women and children under 5. So why is my thing not going to, okay, sorry. So the work around gender and malaria is comparatively a new field, and there are not many examples of best practices of programs that address gender dynamics around accessing treatment for malaria or preventative tools. As we know, a mosquito doesn't discriminate in biting men or women, but there are many ways in which gender can influence who gets malaria and how it is treated. In addition to children and pregnant women being biologically more susceptible, social, economic, and cultural factors play a role in determining differences in women and men's vulnerability to malaria and their ability to access prevention and treatment. In particular, and Gemma also touched on this, there is this growing evidence that gender-specific effects of malaria are felt most acutely by poor, rural, and marginalized communities and women, indicating that development, gender equity, and health outcomes are intrinsically linked. And yet very little work has explored the ways in which the risks and effects of malaria are determined by the intersections of sex, gender, and poverty. So last time I spoke with, I think, the same crowd with all of you, we spoke about gender and what this means. So I won't go into as much depth as I did last time, but I will provide you a bit of a reminder. So gender refers to socially constructed characteristics of women and men that we all learn through our own social structures, such as our own social norms, the roles and relationships that we all have between groups of women and men. So we are born male or female, but we learn to be girls and boys, and we grow up to be women and men. But sometimes people have a gender that blends elements of being a male or a woman, blending masculinity or femininity. And sometimes people don't identify with any gender. Sometimes people's gender changes over time, and people whose gender is not male or female use different terms. If they don't identify as a man or a woman, they use different terms to describe themselves, such as non-binary being one of the most common terms. So when individuals or groups do not fit in to established gender norms, they face stigma, discrimination, and social exclusion, all of which adversely affects health, and this happens in malaria too. So I just wanted to speak to some of our priorities as a network, as Women for Global Fund, around malaria. We've really been advocating for the creation of a gender assessment tool to monitor malaria, conduct research on the barriers and differences of men and women in accessing treatment for malaria. So the Malaria Matchbox tool was created to illustrate the idea and to shed light on the different types of barriers that people face to access and utilize healthcare services. Really, looking at what those barriers are, social, cultural, financial, physical, all related to gender norms. And it's an essential step to match people's specific needs to responses that are person-centered, rights-based, and gender responsive. So I wanted to ask you, this was presented on the last webinar. How many of you actually have taken the time to check it out? If you can I ask you to put a yes or a no in the chat box? And when the next speaker is speaking, I will also add a link to this for you to review in the chat box. There are also other documents here which are really important. They're all up on our website. Another area that we need to get right is around data collection. As I mentioned on the last webinar, and this was actually mentioned by Katia Burns and Carrie Green, who presented some of this. They were both on the technical review panel. They were saying that country level data systems are not currently designed to produce sex disaggregated or gender specific data beyond just looking at pregnant women. So we have a long way to go. And from my understanding, the data that's collected at the facility level is disaggregated by sex only. And that disaggregation kind of gets lost as it moves up through the system. So I'm not working at a national level. It would be good to hear from all of you when we have time to talk, if this is the case and what we might be able to do to change this. Collecting data is difficult, it's costly. And so, we really do need to advocate for community-led monitoring and participatory approaches to collecting data. Even like organizing a community mapping can be so powerful to gather disaggregated and gender-specific data and enable communities to think about their own solutions to the challenges that they are facing. So as we know, the new strategy is being developed, as Gemma spoke to, and once that is done, they will start to develop the key performance indicators around how they roll the strategy out and how the Global Fund tracks their success. And so one of the things that we are calling for as a movement is to ensure adherence for countries to really adopt and adhere to a minimum gender equality standards. Just like they have the same human rights standards for the Global Fund grants, they should also have a minimum gender equality standard. And this would cut across HIV, TB, and malaria. So my next slide just points out some of the key highlights around the technical review panel report. So this is the group, it's an independent panel of experts that reviews all the funding requests that are submitted to the Global Fund for consideration. And our own observations and experiences as Women for Global Fund advocates at the national level very much align with the findings of the TRP, which note, and this all comes from a review of Window 1, so this first little box up here just says that, you know, it's really concerning that the areas of addressing gender-related barriers to services, there were only 44% of the funding requests in Window 1 which were assessed as good or very good, versus the 56% in the 2017-2019 cycle. So this was, you know, gender equality was the weakest aspect of the most recent Global Fund proposals, and that's really worrying. Another finding here, specific to malaria, was that the TRP is still reviewing a number of gender-blind funding requests with limited attention to the gender dimensions of malaria. Again, inadequate use of sex and age disaggregated data. The malaria requests, and this is a strong plea, you know, this is a really important point, that there is technical assistance that is available. And even if, you know, we don't all know how to do this, we should be applying for technical assistance so that we can take any analysis that has been done and actually turn it into programming based on evidence of inequities in access to services. And we also see that around community systems strengthening, which Wanmus spoke so eloquently about, this often gets confused with community health workers. It's conflated with community health workers, and we see that funding requests fail to prioritize funding for effective programs for and led by key populations. And few of the proposals address the broader dimensions of community system strengthening, including capacity building for key population-led civil society organizations, or even, you know, just creating an environment that's based on human rights and is sensitive to gender. So my next slide, I'm not going to go into too much depth in because I spent a lot of time on this last time, but I just wanted to highlight again that despite the gains that we've made to increase prevention efforts, the malaria response has really failed to delineate and disaggregate data that shows a clear picture of how men and women and non-binary people across their life course are differently impacted by malaria. So our gender expression, our identity, our orientation, and our actual sex does affect how we access services and treatment. So a lot of malaria programming focuses on universal coverage, but women, especially young women, adolescent girls, women from key populations, face greater barriers to accessing services. For example, you know, many women are economically dependent on men, and gender-specific barriers include distance to getting to a clinic, cost of getting there, stigma associated with accessing service and treatment. You know, in some cases, male healthcare workers might be healthcare providers in a village are men, and this challenges young women to be able to venture into that person's home to have a 30-minute malaria test or to receive counseling. And again, populations who are criminalized because of their identity or sexual or expression are also less likely to access services if they know they're not going to be welcomed or could be at risk. So I just wanted to go over the slide again, because I just think we need to keep beating this drum, that we need to move along the gender equality continuum. So this framework categorizes approaches by how they treat gender norms and inequities. So the gender equality continuum tool takes users from a process that's maybe gender blind to gender aware, towards the goal of gender equality and better development outcomes. So a gender blind or negative or neutral intervention really aggravates or reinforces existing gender inequalities and norms, and doesn't really acknowledge the different gender needs and realities of women and men or non-binary people. On the other hand, a gender aware program or policy deliberately examines and addresses any anticipated related outcomes during both design and implementation. So an important prerequisite for all gender integrated interventions is to be gender aware. A gender sensitive intervention takes into account differences and attempts to ensure that women will benefit from the intervention. A transformative intervention really seeks to redefine and transform gender roles and creates equitable gender norms and dynamics and relationships in order to redress existing inequalities. So it's really important for all of us to be interrogating how programs support men and women, girls and boys differently, and to take consideration their realities. We have to start avoiding gender blind strategies, because this just ignores some of the underlying factors that we may be missing in being able to start to really reach the targets that we need to reach, as Gemma was saying. So I've got 3 slides left. I just wanted to touch on this slide. I presented it last time, but I'd like to give you a little bit more information on it this time. So as you will see in this slide, there are differences when we talk about gender equality and when we talk about gender equity. So this would be gender equity and this would be gender equality. And there's an ongoing discussion around this right now. So I wanted to just raise it as an issue for you to all be aware of. Gender equality means that everybody gets the same thing. So equal treatment of women and men in laws and policies, equal access to resources and services within families, communities, and societies at large. And you can see that even though everyone got the same thing, this little person is still no better off and not able to see. Whereas if we focused on gender equity, this is more about being fair and justice in the distribution of benefits and responsibilities between women and men. And it often requires women-specific programs and policies to end inequalities. And this is important because in the context of the Global Fund, in the last year or so, there's been much more of a focus around gender equity, which is often a much easier conversation to have at the national level, because it's harder for countries to think about equality. It's easier to think about equity. But what we are actually calling on the Global Fund, as from an advocacy standpoint, we believe that we need to keep focusing on gender equality, and that the Global Fund, whilst we respect that every priority, every country will have its own priorities and they will differ in each country, the Global Fund strategy should be really clear that it supports countries and that the support will only be provided to programs and services that are gender transformative or at least gender responsive. But this should emphasize that whilst the Global Fund is committed to being driven by data and respecting that in many contexts that will mean focusing on adolescent girls and young women, the overall goal is to achieve gender equality across HIV, TB, and malaria for all women. So the new strategy, we hope, will set a real direction that affirms that the Global Fund will not support programs that are gender blind or merely gender aware, because we have to stop doing that if we're going to, push countries, support countries to move towards gender equality. So this slide is a very short summary of a paper that was submitted to the Global Fund for consideration as part of its first deadline around the online consultation of its new strategy. The paper is a result of a consultation that we did with our strategy working group, which brought together 64 people from 31 countries. So a gender-sensitive and transformative response is really no longer nice but not essential. And we feel that anything that is done without a gender lens is going to fail to achieve the last mile. So unless if you want to progress, to deliver on SDG 3, which is to ensure healthy lives and promote well-being for all, you have to actually deliver on SDG 5, achieve gender equality and empower women and girls. So these were just, the things that we're calling for. We're calling for the Global Fund to sharpen its commitment to gender equality, to really start to support some issues around sexual and reproductive health and right, really require women-centered and community-led data collection, monitoring, and evaluation, and to invest in our communities for programs and advocacy, and to meaningfully engage us at all levels of decision-making. And I think those are apt for the response to malaria too. And my last slide is a borrowed slide. It was from a webinar that we presented, we hosted together with Abcaso and Ianaso. And this was a slide that was presented by Adi from Abcaso. So I've slightly adapted it, but it's really Abcaso's slide. And the reason I wanted to put this here, and again, Gemma mentioned these 4 strategic objectives at the beginning of this webinar. And as a movement and a network, we tend to focus on this one, strategic objective 3, to promote and protect human rights. But actually at the national level, some of our advocates are saying that they spend much more time focusing on this one because of the community system strengthening aspect, which sits in strategic objective 2, which is to build resilient and sustainable systems for health. So we really need to think, about the different opportunities that exist to be able to integrate gender across the strategic objectives that we are focusing on. So Adi's key takeaway messages, which I want to leave you with too, are that there are pathways to propose funding of whether it be civil society, community system strengthening interventions across the different Global Fund grant components, within and outside the RSSH grant, or even after signing the grant. There are lots of different ways to be able to push for the stuff that's important to us. We may not know all the technicalities of how to operationalize CSS or gender in malaria, but there are, there's the CCM that we can push to make sure it happens. There's the principal recipients, there's the writing team who often have paid consultants to do this work, and there is TA that we can also access to be able to support us to do this. We know what we need to know and stand firm on is that addressing gender and CSS is essential. It's no longer nice, but not essential to the effectiveness of Global Fund grants. And the Global Fund knows the importance of this, and that's why they support these things. So it's really important for you to know that, because if your countries are saying to you, well, that's nice, but the Global Fund doesn't support that, you know that they do. Our role and our challenge is to make it our country's will to have community system strengthening, to address gender inequities, inequalities in Global Fund grants. And finally, that the Global Fund has allocated technical assistance to support you in these under the Community Rights and Gender Strategic Initiatives. So please tap into these, tap into the community platform groups that are there to support you. So the message was, and we agreed, to stand together. We need to have women and men advocating for gender equality who are engaged all the way through. They are always avenues for intervention at any stage of the Global Fund grant. And I really would encourage you to go, I'll put the link in the box, listen to this recording on our website, because Olive also presented, and RD's slides really were fantastic. And there's lots of learning to be shared. So thank you so much, and I hope I haven't overspoken.
Thank you so much, Sophie, for taking us through, reminding us around gender, the terms and gender equality, gender equity, but also giving us tips on what we should be looking out in terms of programming, malaria programming, and integrating gender within the malaria programming. With this, I won't take long. Let me give the space to Carol. Carol, give us 3 pointers on how you have been able to integrate gender within any of your Global Fund grants that you are implementing. Over to you, Carol.
Thank you very much, Olive, and thank you to the earlier presenters. So like Olive said, I'm Carol Kachenga from Sitam Plus in Zambia. Though I'm going to talk more about TB in the mining sector, I'm also the person who's the focal point person of the community engagement on malaria elimination in Zambia. So we're members of the CS4Me, and I'm the co-chair of the CCM pillar of the CS4Me. So we are doing malaria work and actually using the examples, some of the examples I'm going to share now as we are strengthening the malaria work in the country. So I'm going to share the part where at Sitam Plus, we were lucky to be selected as one of the SSRs, the sub recipients of the Global Fund Regional Grant on TB in the mining sector. So when we're doing this work, we ensure that even from the beginning, even as we are writing the concept note, we ensure that the miners themselves, the affected communities, the miners, ex-miners, were part of the process. They're part of the delegation that we're putting together the concept note. But even in this group, we ensure that there's artisanal and small-scale miners, and ensure that part of these were women in mining. From doing this work, and the reason we did that is wanted to ensure that there was integration of gender equality within the grant, and just to ensure that there's that sense of gender in the concept note. We also made sure that some of the civil society members, even up to now, they're part of the regional coordinating mechanism, which is like the CCM, but they're at the regional level. And then even with the other proposals, because there was the TB in the mining sector in short is called teams. So there was teams 1, teams 2, now there's teams 3. We've ensured that we have the miners, ex-miners, and the mining union groups there, including the women in mining. So I think as I start, just to talk about the key populations for TB in the mining sector, we are targeting the miners, ex-miners, their families, and their mining community. So as we started, in order to build the capacity of the civil society around the areas and their communities, and also to support women empowerment, one of the areas that we made sure were in the grant was to come up with some kind of community system strengthening toolkit, the team toolkit. With this toolkit, actually part of it was supported by YENASO. The areas that we looked at, that the modules that we looked at were, for example, to ensure that the mining communities and the miners know, especially the wives of the miners who go out there to work in the mines. We started with the first module, looked at introduction of TB and silicosis, and then we also looked at right to information. The other one was right to health and workplace policies. Another important one was right to compensation, but also knowing the other one was families and spouses, policies and perspective. The main one, I think the presentation I'm making is really around the gender and gender equality. It was a big module in that. We also looked at appropriate and quality of service delivery as well as community advocacy. And the reason why we really, this was important, as we went out into the community to train the communities and the miners and ex-miners, was that it was found that in most cases, like I said before, you find that most of the people who go out, especially cross-border miners, were men. And when they come back, they sometimes come back with TB and they don't tell their wives. So that's why it was important for them to know the signs and symptoms so that their wives are able to support their husbands and their families. But also that the miners themselves and ex-miners also needed to know the procedures on claiming compensation. It's one of the areas that we looked at. And also talking to the mining sector themselves to ensure that they put policies in place that were user-friendly around compensation and provide clear information on compensation. What we wanted to really make sure was that they also know that mine workers have the right to compensation, and the employees needed to provide information on how compensation claims can be made. So we did the trainings, we went to the ground and we trained the miners, ex-miners, their communities, as well as artisanal and small-scale miners, and specifically other meetings with the women in mining. The other campaign that we had, I think I'll go quickly in the interest of time, was what we dubbed the HER campaign. And this campaign was where we worked with just now women in mining. They were the big scale miners as well as artisanal small scale miners. And the activity focused on women in mining and the mining sector to raise awareness on human rights and the policies that guide women in the mines. What we noticed is that, like I said, in most cases, you find that for the women, they will be small scale miners and they did not know their rights. Most of the cases they were taken advantage of. Even those who worked for big mines, if they got pregnant, they were also sometimes just laid off without being paid, and sometimes given, instead of being given lower or jobs that were not that heavy, they'll just lay them off and not pay the money. So we thought, let's work with the women in mining to support them with this. So with this, we targeted educating the women about their rights on compensation as well, and also on gender balance, and also to provide more information about mining policies that are available in the country. In most cases, women being small-scale miners, they wouldn't bother to look at the policies. When we're actually training them, most of them had never seen any policy documents around mining or around compensation. So we went through, found out what policies existed in the country, and for those who could not fully understand the language, we unpacked it and brought it into a language that they could understand, and also directed them to areas where they could claim. Because a lot of people had their family members who had passed on, their fathers who had passed on, that never claimed compensation, or some of them their husbands. So this also helped. So we did a campaign where one of the things that we did was to form a platform for women in mining. And this is a platform where women are given an opportunity to identify issues that are affecting them and to find solutions for them. We were lucky for us because the person who is the chairperson of the Women Association of Women in Mining, who is also part of the team's RCM, also joined the work that we're doing, and she helped us identify a lot of women around the country. So the platform that we have has over 300 women in mining. And out of that, we also thought, how do we now get women who are strong enough, who can articulate issues? We decided to identify what we call women champions in the mining platform. And these are the ones who we build their capacity and they're able to now go after they identify issues of the other smaller mines, they take the issues to the larger platforms. For example, they're able to go and conduct specific gender awareness programs in large-scale mines and human resource to look at the policies that affect women. So they do that, and then they bring this back to the platform. And then when the women who have issues, then they can do that. At the same time, the same women are able to engage with policymakers. We found that a lot of them, as I said before, they were small-scale miners. They were having problems with headmen in the areas where there are mines. You'd find that the people were coming to encroach on their lands, and because they were women, that was becoming a bit problematic. So with this, we're able to put them together with either the mayors or councillors of those towns or their MPs, where the areas where they had their mines, and most of them had their traditional land secured and were able to continue with their work. The other area where they looked for was really advocating for incentives for women working in the mines. So this same team did the same thing and supporting the women. What we are doing as an ongoing work is we have a tool that our community volunteers use as they go out to do awareness raising and screening for TB. They're also going out with a human rights tool that collects information on human rights violations. We are hoping to put that together and hopefully in the future share that with much, much more. I think as I close off, I just thought I should talk a little bit about also the work that we are doing here in Zambia, where we just finished writing our global funding request, and we recently got feedback to start our grant making process. What we did here was, as civil society, we really made sure that when the principal recipients were coming together to do the funding split, we were there. And even when we were writing the proposals this time around, we ensured that the RSSH component, we picked out the community system strengthening component of this and worked on it ourselves. So even when the two PRs, we have the government and the civil side PRs were like fighting on the split, we were able to say which funds should go to which PR and who had the strength in whatever it is. So for those who are listening, for those who are still going to write their funding requests, it's important for you to be there. You could write a good proposal, but sometimes we lose these things when you get to the part of the funding request. Though for us in Zambia, again, we had unfortunately this time a quite gender blind proposal. We did try to push this, but I think we just need next time to ensure that we have maybe gender experts to come and support us. Then the end of this, when you do this, after you've gotten your money and everything's working, it is important to have some people, those who don't intend to apply for these resources, to track the implementation of the grants. That is where, in most cases, as civil society, we fail. We've been talking, the buzzword now is community-led monitoring. So if we can use community-led monitoring to track our implementation, and it's always very easy to do that, especially on the CS component, if you're part of the writing and you understand what is there for you as civil society and which PR is holding your resources and if they're being used or not. Thank you. I submit.
Thank you very much for the detailed presentation and experience, Carol. We really, really appreciate that. And to me, my role is challenging the malaria community here, that we are learning from HIV, we are learning from TB. I know we also have examples from malaria. And the question is, what are the key things that we should be putting in place right now to ensure that we integrate community human rights, community system strengthening human rights and gender in malaria programming? I would want to see your comments in the chat box or within the Q&A so that we can also start highlighting some of those pointers as we continue with the discussion. Right now, let us move forward. I know we are running short of time. We have 35 minutes and we have two presenters. Alexandrina, I know, has just joined us. I think joined us, not just, but joined us from another meeting. And so we are very happy to have you here, Alexandrina. Maybe you may want to just introduce yourself. And then the topic that you'll be handling is the human rights issues or human rights in malaria programming. And after that, we'll hear some comments from Botswana, from Nana. So over to you, Alexandrina. If you have the presentation, you may want to, if you want, let us know if you want us to put it up for you or you'll be sharing your screen. Thank you.
Thank you so much for welcoming me. My name is Alexandrina Jovita. I'm with the Community Rights and Gender Department at the Global Fund. I'm happy to share my presentation. So please allow me to share my screen. Will you let me know if you can see it? Are you able to see it?
Okay, Alexandra, please go ahead. Yes, we can see the screen. Thank you.
Can anyone let me know if you're able to see it or not?
Yes, we can see Alexandrina.
Yes, we can see.
Yes, please.
Okay, so I think I figured out there is an issue with my computer muting me completely when I'm trying to share a presentation. Are you able to see my screen at the moment?
Yes, we can see your screen.
We're able to see it. We're able to see it.
Thank you so much. Apologies about that. At least we figured out the issue. So what I'm going to try to do is give a very brief overview of what we are trying at the Global Fund to do to ensure that the malaria grants, the malaria and SSH grants, have better visibility and understanding of who are the vulnerable populations, who are the underserved populations in the context of malaria, who are being left behind and why. So, okay, so if we look at the figures of what it shows us, and if we look at the commitment, there is commitment in the Global Technical Strategy for Malaria 2016-2030 to ensure universal access to malaria prevention, diagnosis, and treatment. In order to do that, there is also a focus on understanding who are the populations that are being left behind and why. We've seen globally progress on malaria. We've seen an increased understanding that the malaria burden and the mortality reduction can be achieved only through a scale up of expanded coverage of effective interventions and increased resources. We're still off track to reach the ambitious targets. And of course, the COVID situation is going to throw us further off track. And we're seeing unequal access to services across regions and across populations. So in order to speak about malaria control, it is really important to understand the external factors that impact the malaria response, including population growth, including climate change, including how migration patterns, how migrants and mobile populations are accessing services, understanding inequity, understanding how emergencies affect the malaria response. So all that affects, of course, the capacity of the health systems to be able to deliver the malaria services, and it affects on the biological threats as the insecticide, the drug resistance that we're seeing to emerge. So that's why it's important to invest not just in the core epidemiological and entomological capacity in countries, but it's also really important for countries to be able to understand the epidemic better, for countries to understand what are the populations that are experiencing the biggest risks and most barriers. So that's why in order to maximize the impact of the malaria responses, it's really important to invest in community system strengthening. And it's really important to invest in understanding what are the barriers, what are the bottlenecks that are keeping the underserved populations away from services. This is why we at the Global Fund have revised our technical brief on malaria, gender, and human rights, and acknowledged very clearly, in addition to the high-risk populations, pregnant women, children under 5, also the underserved populations that are affected by socioeconomic and cultural factors. And as such, they may be at increased risk of malaria, or they may be unable to access services like malaria prevention, diagnosis, and treatment. This is why the technical brief is based on the premise of knowing who is left behind, including through stratification of data, including through gender and age disaggregation where it makes sense, but also understanding what are the equity barriers that are leaving those people behind, and why are those equity barriers manifesting in that way. Qualitative assessments as a malaria matchbox tool have been explicitly mentioned in the Global Fund technical brief. We are seeing an increased interest and uptake of a malaria matchbox in many of the malaria funding requests that came in. We're seeing also a huge interest from TRP in the malaria matchbox, because there is so much of an appetite of understanding better what are the gender barriers that are faced by women or men. What are the occupational exposure that women or men may face differently? What are the physical or cultural barriers, including literacy, that have been faced by some populations in Guinea-Bissau where we have played the malaria matchbox? What are the barriers that are faced by IDPs and refugees? For example, at the moment, there is a malaria matchbox underway in Nigeria that specifically drills into those specific issues. So it's important to understand very clearly what the barriers are and how they manifest for each of these populations in order to be able to design the best programmatic response to address such barriers. And of course, in order to address gender and human rights related barriers, in order to ensure equity in accessing to malaria services, it's important to have strong community systems. Communities have a critical role to play, not only in the design, but also in the delivery of services. They are best positioned to be able to reach those underserved and high-risk populations. Communities are also very well positioned to undertake community-led monitoring that can help identify and address bottlenecks, and can bring actually to the attention when there are barriers to either availability of services or accessibility of such services or the acceptability and quality. Basically, unless we have rights-based and respectful approaches, and unless we have meaningful participation of affected communities, Global Fund understands that we will not be able to achieve the global technical strategy targets, and we will not be able to control malaria. Well, I am not going to spend too much time on the next slides because to my understanding, we have several of the malaria matchbox experts on this call, including Olivia. I saw her on the list of participants. Olivia is currently the person leading the malaria matchbox in Nigeria, and she's also carried out the malaria matchbox in Niger. There are a number of you that have experimented with the tool before, but what I wanted to draw to your attention is that the malaria matchbox helps us understand who are most affected and why, and they're helping us to understand whether the traditional programming approach works for those people or not. So it's important for us to be able to understand what are those risk factors and how are the underserved populations basically facing a double burden in accessing malaria services. It's not just that they are at risk, it's just that poverty, social exclusion, gender inequalities, cultural norms, other human rights related barriers and gender related barriers conspire to leave them behind in accessing services. The malaria matchbox has several modules, including the module 5, which focuses on using all that wealth of qualitative data that is being collected through the matchbox for action planning. So linking the data with programs, which is really important because unless we take action, unless we shape clear interventions to address these gender and human rights related barriers, then we just stop at having a good report, a good diagnosis of a situation, but we do nothing to treat the issue. Which is why the technical brief that I referred to, the technical brief that Global Fund has developed, specifically looks into how human rights and gender related interventions can be integrated and can become part and parcel of a vector control programs or prevention programs for high-risk populations. They can become part and parcel of the efforts around advocacy, communication, and social mobilization. They can enable case management. They can enable the IRS interventions, for example. So it's not as much as about building separate responses. It's about how do we ensure that the malaria responses, the standard malaria programs work for underserved populations and address human rights and gender-related barriers. The technical brief hence speaks about specific programmatic interventions around assessing inequities, assessing the human rights and gender-related barriers through the matchbox, for example. They speak around specific interventions building upon the meaningful participation of affected populations, about strengthening community systems for participation in malaria programs and programs to monitor and reform laws, regulations, and policies that affect and regulate malaria prevention and control. Such programs can be budgeted under the intervention on addressing human rights and gender-related barriers, which are part of a vector control module, which are part of a case management module, which are part of a specific preventative interventions module. So in that particular intervention, which is quite broad, this is the kind of programmatic efforts that can be budgeted for, and the technical brief outlines in greater detail what each of those areas represents and gives examples of how each of those programmatic interventions can be taken forward. But also it's really important the technical brief recognizes that specific programmatic approaches to addressing inequities are not just left to one intervention to address human rights and gender-related barriers, but they become part and parcel of the overall malaria effort. So when we design, let's say, a mass distribution of our alliance, how do we make sure that they reach that last mile? But it doesn't matter how far those people live. We talk about geographic accessibility, but the nets are brought to the people that need them. But we take into account what are the cultural norms around net use, but we take into account who makes the health-seeking decision-making at household level. And if we have a febrile child, who decides? Is it the man? Is it the woman in the household? Is it a joint decision? And how do we ensure that we can actually address all those gender and human rights related barriers, and we can conceptualize the programs in a way that reach those most underserved populations? What I'd like to share with you in the next couple of slides are actually some lessons learned from TRP. So in the last 3 waves that we've already had, we had quite a few malaria requests come in. What's interesting is that there is a lot of appetite and a lot of interest from TRP in understanding how investments can be improved to address barriers to services for underserved and for unserved populations. So we've heard from TRP that it is important for the programming for such high risk or hard to reach populations to be scaled up. How important it is to have epidemiological and programmatic data to evaluate the gaps and to prioritize interventions, to do geographic and ecological targeting, to understand better through the stratification of data where exactly the problem lies, who are the most affected populations, and how exactly can we conceptualize service delivery to reach those people. TRP has also noted that there is a particular gap for mobile populations, migrants and mobile populations generally, but also specifically IDPs and refugees. TRP increasingly is asking for inclusion of funds for qualitative assessments as the malaria matchbox to better understand the barriers that these underserved populations are experiencing. And actually, to give you an understanding, out of the 31 countries that have received some type of CRG comment from the TRP for their malaria funding requests, 24 of those comments have explicitly referred to the malaria matchbox, either asking for a malaria matchbox assessment to be conducted, or in the case of countries that have already conducted the malaria matchbox, as in the case of Somalia, for example, specifically asking for follow-up to the malaria matchbox recommendations. What that means? That means that the TRP is going to have increased scrutiny on the issue. It means that the applicants are going to have to respond back to the TRP and explain clearly what are they doing to address the human rights and gender-related barriers. What are they doing about the key and vulnerable populations? What are they doing about the underserved populations that are facing barriers to services? So this is an exciting opportunity, but of course it's up to the communities. It's up to those communities that are represented in the CCM. It's up to those communities that sit in the oversight committees to take this opportunity forward and to ask for accountability and for greater scrutiny and understanding of both the barriers and the people experiencing them, but also the programmatic response needed to address such barriers. TRP is also interested in seeing specific funding being dedicated for technical assistance. They want to see a translation of such qualitative analysis and of qualitative and quantitative data into solid programming that is based on contextually grounded evidence. So for a number of countries in your region, some technical assistance may be available through the CRG strategic initiative or through the human rights strategic initiative moving forward. And if there are opportunities where such technical assistance can deliver the best kind of results, please do flag those opportunities to us. We're seeing from TRP increasing requests for investment in integrated training and other capacity building activities, particularly under their SSH funding requests, but pay attention to integrating equity considerations. So it's not only the malaria funding request that should deal with gender and human rights related barriers and other equity barriers to malaria services. It is any investment in RSSH, any investment in strengthening community systems under the RSSH funding request that can further enable the malaria response. Again, coming from TRP, coming from the lessons learned from the TRP reviews, we see that it is important that we optimize health and community systems investments in order to maximize the impact of malaria control and elimination. And it's about prioritizing generating the data, but also investing in qualitative data that complements the picture that the quantitative data is able to paint. Where there are data gaps, such qualitative data can start indicating where the problem lies so that additional quantitative data collection can be conceptualized. There is also an appetite for increasing use of community-based organizations as watchdogs, as accountability monitors, and increasing use of community-led monitoring to signal those human rights and gender-related barriers and to signal where the programmatic responses can take place. Sustainability of interventions and integration of efforts across the three diseases, but also with reproductive, maternal, newborn, child, and adolescent health has also represented an opportunity flagged by TRP, particularly if we talk about pregnant women, about children under 5, and the importance of using antenatal care and vaccination programs as potential service delivery entry points. Also, we've seen an ask for promoting community health strategies that rationalize how services are best delivered and who is best positioned to deliver a specific set of services. What is the role that community health workers can play? What is the role that community-based organizations and other civil society organizations can play? So who is best positioned to undertake what piece of work, working together in a coordinated fashion to address the gender and human rights related barriers to malaria. And finally, it's important to be considering strategically the investment in human resources so that we don't create unsustainable modalities. So it's important that we develop this cadre of community health workers, but it's also important that we have sustainability strategies in mind and transition increasingly to government funding for such a cadre of resources. I've also provided in this presentation a last slide with additional information and additional resources, which hopefully will be useful to you. And I think I'll stop here and see if there are any questions that you would like me to respond.
Thank you so much, Alexandrina. Thanks for the detailed presentation and actually highlighting the TRP comments, some comments from the Matchbox, and opportunities that exist and areas that as civil society we can take on. So we have one more presentation, I'm so sorry, and then we'll come to the Q&A or just a discussion. So Nana, you're next, and just give us 3 highlights. I know you're not going to be talking about malaria, but we are all learning from other diseases, and Alexandrina actually did present around malaria, but Nana, please provide us with 3 examples of how you've integrated human rights in your programming. It looks like Nana is not online. I think maybe her network has disconnected. So can we, can I move, maybe as she joins, can I move to Zainab, if you can take us to the Q&A session so that we can have some discussions. Yeah. Over to you, Zainab.
Olive, can you hear me?
Yes, I can hear you now. Thank you, Zainab.
Okay, great. And thank you very much for all the presentation of our speakers. So now we are on the Q&A session. I will try to read some questions. So we have 2 questions for Gemma, but we will send them to her, and then she will give the answer. We will send it to the participants. So from Lewa, the question is, how will you increase the frequency of trainings and capacity building for community strengthening so that the gap seen in communities' abilities to play their roles in effective community system strengthening? The training gaps are usually far apart such that some part of the training is lost by the beneficiary before the training. So we'll ask also another question. Maybe I will have a session of 2 questions for the participants so we can move quickly. So the second question from Lewa is, how can a competent but nation organization be involved with implementing malaria projects at the community level? Because in most cases, there are some communities suffer because of fewer or no malaria program reaching them. We also do not have an alliance, just like TB or HIV organizations, that are not strong enough to link up organizations with community in need. So the question of Demonio Amboto is, don't you think to ensure strengthening systems, we may need to improve strategic plans for CBOs? So he's explaining that he's mentoring 15 organizations in Kenya, and he found organizations still struggling to find their way. Thank you.
Hello?
Yes?
Hello. Hi.
Oh. Yes, Nana, you're
can you hear me? Oh, yes, you can hear me now.
Yeah, we can hear you.
Okay, great. So sorry, guys. I think I had a connection issue. So should I go ahead?
Yes, please, Nana. Do go on ahead. Yeah.
Great. I'm even going to skip the introductions because I think time is not on our side. But Botswana has a TB HIV grant, and the organization I work for implements the human rights, removing human rights related barriers to health services grant. And so I'm just basically going to take you through some of the kind of programs that we implement and the principle behind how we implement. So our programming really is aligned to the UNAIDS recommendations. We basically implement programs that address and reduce stigma and discrimination. We implement programs around training and sensitizing healthcare workers. We also implement programs around training and sensitizing law enforcement officers. We provide legal support. We do legal and human rights literacy. We do monitoring of laws and policies that inform programming around the diseases. We also do programs to reduce gender equality, harmful gender norms, and discrimination against women. We also try to incorporate this programming with other modules that are being implemented in countries, so that then there's a maximum impact from the human rights interventions. As you know, human rights is a cross-cutting issue. Human rights and gender are cross-cutting issues, and therefore it's really important to basically not do it as a standalone program. Specifically, in terms of the process that we use to address health issues, we use the 7 principles of the right to health. I think lots of colleagues have already talked about the issues around availability, accessibility, acceptability, good quality, participation, accountability, and the underlying determinants of health. As you know, human rights, gender, these are issues that affect a person. And as long as something affects a person, you have to also look at the other issues that affect them, particularly around housing, food, sanitation, safe drinking water. These are all concomitant factors that you have to consider when you're doing human rights and gender programs. I think Alexandriana talked, specifically around programs that can be implemented for, by malaria colleagues, taking into particular consideration for target populations that are most affected. One of the examples that she talked about was pregnant women. So for example, as we are implementing our adolescent girl and young women program in Botswana, then there's opportunity to work with malaria colleagues to say, those that are pregnant, for example, and therefore, particularly vulnerable to malaria in our malaria endemic region, how about we do interventions together? So in Botswana, we have a program called CATEM for our malaria program, which is communities acting together to eliminate malaria. And it's a model that we brought in because also we're having a transition grant for malaria. And it's really important that whatever programming we do, the government is going to take over because it's our last grant. It ends in 2021, and all the programs have to be sustainable. So, and with the CATEM model, basically communities sit, they understand what are our issues, what are the challenges with people taking up services, what are the challenges with access, all the things I mentioned in the 7 principles to the right to health. And they sit down and they agree per community what they need to do to address these things. And so it makes it a much more inclusive and integrated approach to addressing the disease. Like other colleagues have said, I think HIV, TB are further ahead in terms of engaging on these issues, particularly around human rights and gender, and really appreciating the specific considerations. So particularly there needs to be a lot more work that's done around literacy. For example, I think somebody put in the chat, what are the specific kind of programs that could be done? Again, I'll go back to the whole issue of adolescent girls and young women. If you're doing a malaria program in a country where you have challenges with literacy rates and people can't even read what it is that you're trying to inform them of, or are not in school, or are, you're dealing with adolescent girls who are, for example, pregnant, you could put in place a study program that is helping them with education on the one hand, but also, giving them all the education they need around malaria and how they, can, support case management, can support detection, early case management, all those kind of things. And also create awareness around why it's important to use the nets, why it's important to support the people who are coming to the community to spray. So it's really important to see how the program that you're doing can integrate with other programs that are already being done. and that even, you know, supports impact, it supports taking programs to scale. Right now, with resources that are limited, it's really, really important to see how to integrate these programs. So because we don't have much time, I was actually initially going to go into detail about specific things we do. And I think Sister Cecilia talked about it in their program. We do similar programs. We have paralegals, we have reactors, we have people on the ground, you know, who basically identify issues that are happening in communities and elevate these issues to their district health management team, who can address it. If they cannot, it's also elevated further to, you know, for legal support. We also work specifically with key stakeholders in the district to address issues where people cannot have access to healthcare. For example, some rural communities, because of where they're situated, people haven't had access to their national identity cards. And in Botswana, you need a national identity card to access health. We work with the relevant authority in that district to support them to get it. Also to look at the policy, because the policy says, no, you pay 100 pula. Maybe people don't have 100 pula. Because again, poverty, you know, plays a role in what is happening in terms of accessing health services. So we basically negotiate with the relevant authorities to say, can you waive this fee so that more people can get their ID cards and access health? So it's things like that. But it's basically working with specific communities to ensure that we're addressing all the challenges that affect people's capacity to access health services across the 3 diseases, HIV, TB, and malaria. Not sure if I missed something. Just trying to rush. Hello, can you guys still hear me?
Yes, we can hear you, Nana.
Okay. I think one of the issues that is particularly important really is around sensitizing healthcare workers. Because like some colleagues said already, when you talk to malaria colleagues, they often say, but I don't know what you mean. What issues? There's no issues. We use a universal approach. So we provide the service to everybody, but it is really important for them to better understand what are the peculiar challenges and the intersectionalities and the double vulnerabilities, like Sophie talked about. You know, we're addressing women in all their diversity. So it's really important for them to be trained on that so that they understand that when, as a trans person, I walk into a health facility and I still want a medication for malaria, I'm not turned away because the person has stigmatizes me. So it's really, really important that they understand that as long as a person has another vulnerability, it is important that they basically use a different approach to provide the health service. So these are, yeah, some of the things I thought it was important to say.
Thank you so much, Nana. And I think thanks for hitting the point on leaving no one behind, and
Yes.
especially understanding the point that, you know, there are different vulnerabilities that different communities come with. And even within the malaria, if we generalize access to treatment, then we may be leaving out actually some key populations, which we normally do not deal with. So I just want to say thank you and apologies that for the technology, but we are very at the last minute. Now, coming back to Zainab, I think you had asked some 2 questions to Mlewa. The very first one was around, can I see? Some of the questions have actually gone out, yeah? You had,
yes.
Yeah, some of the questions have. I think you had also asked the question about competence, but nascent organizations be involved with implementing malaria projects at the community level, because in most cases, some communities suffer because of fewer or no malaria program reach. But I've also seen another comment, the last one from Josephine, who is saying, I would like to hear from Onesimus or Cecilia, what kind of capacity building can be given to communities to enable them to play a more effective monitoring role where implementation of malaria intervention is concerned. We have 4 minutes, so let's give these 2 questions to Mlewa and Cecilia, and then we'll come to Alexandrina and Sophie for other questions as well. Yeah.
Thank you very much, Olive. The first two questions that have been asked and actually seem to have moved out of the chat boxes because I've responded to them, and I thought probably as I was responding, they were going somewhere. I don't know why they were disappearing too. But well, they were related to how can we ensure that communities have the right capacities. And if you look at the 6 core pillars that I just presented on community system strengthening, these are pillars that are actually within the Global Fund CSS framework. And ensuring that communities have the right capacities, you definitely need to, you can actually program for these core pillars. The Global Fund actually allows within RSSH for you to be able actually to request for high impact capacity strengthening activities that can actually be funded within the country grant. So during the fund request and grant making processes, you can actually be able to identify high impact capacity strengthening activities that can actually be supported and funded through the Global Fund country grant, so that you can ensure that communities have the right capacities to be able actually to support the grant implementation in country. And when it comes into how can communities be able to be more involved, basically this aligns to the first
Hello, Mlewa? Yes, now we can hear you.
Mlewa, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, we can hear you very well now.
Yeah, thank you. So I said that the last one relates to the first pillar, which is community systems, which is community-based monitoring, which allows for communities to generate sufficient data to inform programming as well as for advocacy for improved health services. Thank you, Olive.
Thank you so much. There are 2 questions I would like to give to Alexandrina. There's one which is around under the CSS component as the Global Fund support operational costs, and they're asking because there are some other governments or other big organizations that provide management costs, but when it comes to civil society, normally this is not the case. So probably you may want to just provide some more information around there. And there was also another question around there was one question on CCM, country coordinating mechanisms. I feel like this is someone who just wants to know more about country coordinating mechanisms, and probably maybe you can just give a short synopsis of what's happening at the Global Fund, if you're able, Alexandrina. And then we'll come to Sophie. Your questions are also going to come up. I know Cecilia also wanted to say something, but let's just move and then we'll come back to Cecilia.
Apologies, I had issues unmuting myself. So on the first question around program management costs and whether they can be budgeted under the community system strengthening module. So basically, under the community system strengthening module, we would like to see programmatic costs. However, that's not to say that costs related, for example, for capacitating communities should not be included under that module. So as long as there is a clear link with a programmatic activity, such costs related to staffing, relating to support enabling implementation of a CSS module can be budgeted under that module. Under the program management module, there is also ability to budget costs related to community-based organization or civil society organization implementation of programmatic activities. So if a civil society organization has been selected as a principal recipient or already has been selected as a known sub-recipient, goes on from the previous grant, but in the program management module, there can be costs set aside, including incentives for the principal recipient or sub-recipient staff. So a quick answer would be if there is a linkage with a programmatic activity, then the costs should and could be budgeted under the CSS module, or they can be budgeted under the intervention to reduce human rights and gender-related barriers as part of the malaria modular framework, let's say the ITN module or the case management module. If the cost, however, is related to the overall operation of a program, particularly to the function of a principal recipient or a sub-recipient, then such costs should be budgeted under the program management module. In terms of the second question about the CCM and how it functions and the CCM evolution, maybe I can ask Ed to come, as I think he would be the best placed person to be able to respond to that question.
Sure, thank you, Alexandrina. And just to say that I have learned so much from you and other colleagues on the call today. So on the CCM questions, as you know, some of the countries are selected as CCM evolution pilot countries. That means that the functionality of CCM are categorized by different criteria, right? You have a very full-fledged, well-functioning CCM, or you have the CCM that are less so functioning. And as part of that functionality, it includes the ability of the CCM as a mechanism to have the feedback loop and rapport with communities who are affected by the 3 diseases. And this has become so important because we know, and you know very well, that in the context of malaria, we often have the representative from the big NGO who implement malaria program rather than the community who are affected by the diseases to participate at that level. So your question is, you know, what should we do? How could we benefit from the CCM evolution? Definitely, I think one way to really influence is to know your representative who's sitting on there. And if, of course, there's an opportunity to voice your concerns, either through your own representative or to really appeal to the CCM Secretariat and CCM membership as a whole, that the composition is lacking affected communities, and ask to be joining as a formal either alternate or the main CCM representative, or make a demand as well to organizations to provide support to understand how the CCM functions, what's the understanding around the roles and responsibilities. And I know that the UNASO has been a key partner in really providing materials and providing education and capacity strengthening related to CCM. So that would be critical. And if your country is part of the CCM evolution, definitely looking at how your CCM is function, engaging with the consultants who are providing technical assistance to assess the functionality of CCM, to develop an improvement plan. I think that would be the way that you could influence if you are not already a formal membership in the CCM in your country. Over.
Olive, can I just add a little to what Mewa answered? I was muted now.
Okay, Cecilia, please do add. And then after Cecilia, Sophie, there's a question on gender disaggregated data. It will be key for you to also respond to that. I just wanted to say thanks for the clarification on CCM evolution, Ed, and I know that we are running out of time, but over to you, Cecilia, and then we'll come to Sophie on the gender disaggregated data.
Thank you. I had a challenge. Just to add to what the answer on capacity building, I believe civil society and communities need capacity building that any other organization, government needs. Our core responsibility is holding duty bearers ourselves accountable. And so I will really say that advocacy, community monitoring, when you talk about CCM, and even implementation, understanding implementation, we need capacity building as strengthening our M&E systems, our accountable financial systems, and we also need resources that will carry us to the communities to do monitoring. So I will say that including, apart from the capacity building, equipment and others that will make us stand and do what we're supposed to do, just to add to what Mewa said. Thank you very much.
Thank you so much, Cecilia, for that comment and taking it to the practical point. Can we now request Sophie? There are two questions that is related to gender-based violence how the Global Fund is planning to support civil society in terms of funding. And then the other one is the importance of disaggregated data, gender disaggregated data. Why do you think it's key?
Thanks, Olive. I had actually answered the one that Karine just shared, but maybe it got lost in cyberspace. So I think that sometimes from the way the question is, how's the Global Fund planning to support civil society organizations in terms of funding? Sometimes the Global Fund is not the problem. Sometimes it's the countries that we have to convince that this is an important issue. And so it's important for us to know where the entry points are when we're working on the funding request to get that support to be able to do the work, either as a subrecipient or to get components funded through the community system strengthening modular framework, or if the grant is not functioning, and you've got money left over to kind of advocate for that money to go towards communities to help do the work. But I think the point I want to really make is often the Global Fund does allow for these, but it's just the countries that are not enabling that to happen. The other issue around disaggregated data, and it's such a huge challenge, we were really advocating for women-centered and community-led data around monitoring and evaluation, because it's only through these regular measurement and evaluation that countries can remain focused on what the real needs are and deliver programs that have impact and actually improve results. So this principle of why are we collecting data, for what? It seems to have been forgotten as the whole world has been driven by these global targets, and everyone is, just driven by global targets that are set by technical partners to achieve political ambition. But why are we actually collecting the data, for what? So we're asking the Global Fund, as it's rethinking its strategy, to really be part and parcel of something that ignites a data revolution, taking innovative steps to measure needs, priorities, and progress so that countries keep focused on the needs and priorities of our populations to inform programming improvement throughout implementation, by ensuring transparency of data so that information and learning is shared amongst all partners. So if you want to know more about what we're advocating for, please dropping a link in the box now. There's a lot more on what we need in order to make that happen, and that has been shared with the Global Fund for their consideration. Thanks everyone. Great presentation, great session. Thank you.
Thank you so much, Sophie. I know that there are two people we still need to hear from them. That is Carol and Nana. I would want to just understand just one quick question. There's a question from Rajabu Kimosa that's around engaging youth and young people. And I think this also relates to engaging women and women in our diversity. I just want to ask a quick question to you, Carol. What do you think are the two key things that we should consider engaging women? And for to you, Nana, is what are your last words in terms of ensuring human rights in malaria is integrated? If we can hear from Carol and then we'll move on to Nana. I know we are about 10 minutes late, but we'll be closing in the next 2 minutes. Thank you, Carol. Hi, Carol. Okay, as Carol is coming on, Nana, are you still there?
Yes, I'm still here.
Yes, please. Nana, if
you can hear me?
Yes, we can hear you. If you can just give us pointers.
So thank you. I honestly believe that there's a lot of really great resources on how to really go from a gender blind submission to a gender transformative submission that malaria colleagues are currently doing, or if they're trying to reprogram in order to inform the programs that they want to do. I think it is critically important that they look at these resources and really see how to align them to what they're currently doing. But again, it talks to data, because ultimately, if you are doing a reprogramming or you're doing a fresh application, those who are going to review are going to say, what is informing this? Why would you like to make a pivot? So it's really, really important that, again, we look at the whole issue around data. I also think that there could possibly be opportunity, and I don't know if Alexandriana is still on the line or Ed, to really start programs like South-South mentoring programs. You know, you've heard all the presentations that people have done. You know, there have been quite great strides that have been made in HIV and TB. And I think it's really, really important that, you know, malaria colleagues are also mentored in some kind of a really structured way to support them to get there. And I don't know whether it's something that could possibly be done under CRG or whether it's a new thing that we need to advocate for, but I think it is critically important for that level of exchange and support in order for malaria to really basically catch up and also manage to effectively integrate human rights and gender into their programs. Thank you.
Thank you, Nana. Caro, I can see you're online and you were unmuted.
Yes, Olive, sorry. I was trying to unmute, so I didn't hear the question.
Okay, it was around, okay, I think Nana has in a way responded, but in your own words, 2 key pointers on how we can engage malaria community and in terms of around CSS, what are the key 2 things that work on strengthening?
I think the best way would be to maybe learn from our HIV colleagues, or even the way the TB community is coming up, to come up with a cadre of people who fully understand malaria and also speak for themselves. I'll give an example, like the way it has been here in Zambia. We had the Ministry of Health failing to absorb the malaria money. Every time we looked at the dashboard, for community system strengthening, it was important. I mean, it was always red on the dashboard, always red, because they said they didn't know how to engage communities. So I think getting a cadre of civil society who understand issues and also who can engage the, in Zambia we call them the Malaria Elimination Center, or whatever you call the malaria, the Ministry of Health malaria team, to engage them and also to help them understand how they can work with the community. Because then if we don't, at the end of the day, you find that the government, to make it easier, they'll go through their districts. In Zambia, they'll get all the money for civil society and send it through the districts. Again, to share a quick example for Zambia here is what had happened is they were looking for civil society organizations that are working in malaria. They couldn't find them. They went to the registrar of societies and only found CITAM and another organization. But in the meantime, all the years they've been sending money to the districts where they don't have civil society organizations. So what happened to that money? It was people came up with ghost NGOs just to absorb the money. So as long as we don't have bodies, we don't have voices who are sitting in the chair as civil society, representing civil society, those problems will always be there. In Zambia, again, just recently, I fought very hard to ensure that we had a seat for malaria. Coming next year in this CCM, we're going to have a representative sitting for malaria. So also having representatives in the CCM talking around malaria is another area that can help. But whatever it is, there has to be the real engagement of people speaking and doing the community-led monitoring and making sure that they're not left behind.
Thank you so much, Caro, for that. And I think the notion of nothing for us without us, and this is an era where the communities are expected to talk on their own, and we are expected to capacitate communities to be able to voice out concerns or to be engaged in various processes happening at country level and especially at Global Fund level. I just wanted to get the final words from Alexandria, and then I will now hand over to Zainab for the final comments and wrapping up. So Alexandria, I think if you can just say your final words as well.
Thank you. I'll just make a call for engagement. The voices need to be heard. It is important for community-based organizations to increasingly occupy that space. We've heard today from all of you, we've heard today from the questions that you've asked, how important it is actually for a light to be shone on human rights, on gender in the context of malaria, how important it is for strong community systems to be in place to enable communities to get engaged. It's important to use spaces as a country dialogue. It's important to use spaces and mechanisms as the CCM in order to be able to bring those issues to the forefront. The Global Fund funds only what comes from countries. It's a principle of country ownership. So it is important that you undertake that advocacy at national level so that the issues are raised in prominence, and it is important to include those in the funding request. There is technical assistance that can be made available. Under the CRG strategic initiative, there is technical assistance for meaningful engagement of communities in all these national processes, beyond the country dialogue, also in the grant implementation, also in the process of grant making to ensure that the funding is not diverted away. So use those opportunities, because unless you use the opportunities, we will not be able to reach those most left behind. We will not be able to end malaria.
Thank you so much, Alexandria, for those comments. So let me hand over to Zainab for wrapping up and closing session.
Thank you very much, Olive. Dear participants, we are coming to the end of our webinar, but I will very want to thank all our panelists, Sophie, who shared some links, some useful links, and for all the presentation of all the panelists. Thank you very much. Our team from ISA and EANA, we're delighted to have you with us today. We will send the rest of your questions, but we finished all the questions, but we will send them to Gemma. And also, as a reminder, to become a member of CS4Me, please send your request by clicking on our website, the www.cs4me.org. But once again, thank you very much for your participation, and goodbye and see you soon. Thank you.
Thank you.
If you want to add something.
Yes, I just wanted to say that we will be having our next session, which will be on community-led monitoring in the next week. So we're looking forward to having everyone join that conversation. Thanks to all the panelists, thanks to all the discussants, and thanks to all the participants. Asanteni sana and stay safe. Wishing you all the best. Bye for now.
Bye, everyone. Bye. Goodbye. Bye.
Bye.
Bye.